Testing. Good morning. I think it's 10 o'clock. Welcome to our June 20th meeting of the Health and Hospital Committee. I'm Supervisor Ken Yeager, Chair of the committee, and joined by Supervisor Simidian, who is Vice Chair of the meeting. We first start off with public comment, and we have two speakers, Leonard Williams and Scott Largent.
Good morning, everyone. Scott Largent. I kind of lost track back there. I was thinking. I've been writing more of those letters, not like the ones they talked about from AA and NA, to make amends with certain people. I haven't talked to my brother in about 10 years. He's a maxillofacial reconstructive surgeon, which is kind of interesting. I could use a set of stones in my mouth right about now. I helped my brother through college, through medical school, through his surgical programs. I'm sure a lot of you being doctors, understand the costs associated with all that stuff and families supporting each other. So I'm trying to put this letter together to kind of have him pull through on a lot of promises that he made to me. And, rather than showing up there in Texas out in front of the surgical center there with my bullhorn, hopefully he can kind of, get on the ball because, when people help you out, that's the right thing to do. So that's one of my letters. And then I'm also putting together another letter for my ex. I've been sober 2.5 years. I'm doing all the right things. I now don't even have a criminal record. I received that letter from probation and parole that states that I completed my drug diversion program. Squeaky clean. Other than the fact that when you run my record, it pulls up every single time I was stopped protesting, even though I was never convicted over it. I mean, they sit there and they look through it and the officers just laugh about it now. I have to write this letter to my ex to make sure that she understands what I'm doing is the right thing. I want to be in my kid's life. I'm battling up against a court system that's very unorganized. Even the visitation that I'm dealing with right now, I have to go to a location off of Coleman, and I'm very good with children. I taught children for 20 years doing martial arts. I hang out with all the neighbor kids and stuff. I speak kid. I love children. But when I noticed when they wrote the visitation report on my first visit, it wasn't that it was a bad report. It wasn't a bad report. When you read it over, and I'm sure I'll provide you guys with this sometime so you can understand what I'm talking about, it didn't accurately reflect everything that happened in the visit. I thought for the price you have to pay for this visitation report, it should have not just been one page. And it just didn't explain things properly. So now I've had 4 other visits, and I'm curious what those reports will look like. Now, these people have businesses. They've got to make money, but I think they want me kind of stuck in that system over there. And I do pay $100 an hour to see my child. So you can imagine that. I have 4 hours a week. I mean, the totals of all that other stuff like that. I would rather take that money and give it to my ex towards my child rather than towards making these visitation providers rich. There's no real system in place to regulate these people. They have to do a 2-hour course. They become a visitation provider. Originally, I located a place off of the Alameda. That was $150 an hour, but he was a child psychologist, and he was also a family therapist, which could help me and my ex learn how to co-parent our child rather than duke it out in court. So, thank you.
Good morning, Leonard Williams back again for Patient Family Advisory Team. Again, I want to thank Paul Lorenz, Renee Santiago, and Benita McLaren, who have been so supportive of PFAT. A lot of you have never seen what we do at our meetings, never been to a meeting, and I want to assure you that we as patients run the meeting. Although at East Valley we've had for several years, we've had what they call a champion, or somebody who was taken over watching over us, which was a nurse, and she would run the meeting along with one of our patients. We have now, since she has retired, 2 of us patients have been appointed as chair and co-chair. That's Bob Gazinski and myself. So Bob's chair, co-chair. We set up the meeting, we do the agenda, we invite who we want, and I assure you, nobody tells us how to run our meetings. We have somebody there from management to take notes so that it could go back, so that they know what we're talking about, what we need, and I will tell you, when we send something back to management, we get a quick answer. We are not held up for 2 or 3 or 4 months. The next time we have a meeting, there is an answer, yes or no. So again, I want to thank Paul, Renee, Benita, and all of those who support us. And we have an open meeting, so if any of you feel like you ever want to come out, our meetings are the first Thursday of every month, although we won't have one in July because of the 4th. But we have a meeting the first Thursday of every month. It starts at 1 to 3, and if any of you would like to come out, you're more than welcome to come out and see how we run our meetings, see how we set up the agenda, and see how we get things done. And so I want to thank all of you for your support, and again, for our staff at VMC who has done a terrific job.
Before you step away, I just wanted to say that I not only admire you, but I envy you if nobody's telling you how to run your meetings. That's
Well, I want one quick thing, and that is that, you know, I'm very passionate, and you know what? I will never give this up until the day I die.
Thank you. And then we move on to item 3, which is approval of the consent calendar. Supervisors Committee, and I'd like to put items 9 and 11 on consent.
move approval of the consent calendar as stated.
Great. Then that's approved, and we'll send those on its way. Before we begin our regular agenda, I'd like to take some time to remember and honor a beloved member of the county family who very sadly we lost on June 14th, and that's Dr. Paul Russell, VMC's Director of Primary Care and Community Health. We are going to take a few minutes today to honor Dr. Russell and his tireless contributions toward improving the health of our community, especially that of our children. First, I'd like to welcome Dr. Russell's family, who thankfully could join us here this morning. His loving wife, Mary Ellen Dyer, a nurse practitioner who is dedicated to the health and well-being of children, just as Paul was. And 4 of their 7 children, who Paul was so proud of, and have traveled from all over the country to be with us this morning. His daughter Mackenzie, who has come from Boston, his son Matthew and daughter Grace from the state of Washington, and his daughter Rebecca from Ventura. Thank you all for being able to join us as we say kind words and tribute to your father and to your husband. Dr. Russell probably could have had just about any job that he would want in healthcare, but he chose to come to Santa Clara County. We're extremely grateful for that. We've come so far at VMC these last few years, and Dr. Russell was a very big part of our success. And I think all of us on the committee and in the health and hospital system really know how far we did come from where we started. I'm personally grateful for his leadership in improving access to care for LGBTQ residents. The Transgender Clinic will be opening soon in the Downtown Health Center. This fall is truly trailblazing. Dr. Russell was instrumental in that work, as he was with so many projects. He was a wonderful person and a great leader, and we will all miss him immensely. I'm going to turn it over now to Paul Lorentz, our CEO of VMC and a personal friend of Dr. Russell, to share a few words. Paul?
Thank you, Supervisor Yeager, Supervisor Simitian, and Dr. Smith for this opportunity to recognize Dr. Russell and to share our condolences as well as our deep gratitude to the family of Dr. Russell. The County of Santa Clara, the Santa Clara Valley Medical Center, and the health and hospital system lost a wonderful leader, a dear friend, a colleague, on June 14th with the sudden and unexpected passing of Dr. Russell. Dr. Russell served as our Director of Primary Care and Community Health, as well as a medical executive over pediatrics and women's health. Dr. Russell was a California native, born at Good Samaritan Hospital in Los Angeles, and grew up in Los Angeles suburbs of Van Nuys. Paul was the second oldest of 5 siblings and shared a birthday with his one older sister, Ann. His younger siblings were Mike, Joni, Mary Kay, and Tom. Paul survived by his mother, Frances Swain, otherwise known as Midge, his siblings and his wife, Mary Ellen, his 2 children, Mackenzie and Matt. his 5 stepchildren and their spouses, Dan, and spouses. Dan and his wife, Molly, Katie, and her husband, Pete, David, Rebecca, and Grace. He also is grandfather to 2 boys and 2 girls. Dr. Russell was a board-certified pediatrician. He attended Notre Dame High School in Sherman Oaks and went on to receive his undergraduate degree in biology at UC Irvine. Dr. Russell received his medical degree from Oregon Health Sciences University, and his postgraduate training was completed at Children's Hospital of Los Angeles. Dr. Russell began his career as a pediatric emergency medicine attending physician at Children's Hospital Los Angeles. Dr. Russell also began what would become a long history of volunteerism, advocacy, and caring for the underserved, volunteering as the medical director for the Oscar Romero Community Health Center, where he provided care to Central American refugees. Paul also developed CHLA's first inner-city community-based health program. In 1990, Dr. Russell joined Ventura County Medical Center in its Pediatric Diagnostic Center. While caring for children in his pediatric practice and teaching, he also served as the project director for Healthy Families Ventura, providing prenatal, early interventions for high-risk families in the county. Dr. Russell also ran a special needs clinic for children with behavioral and emotional issues and worked tirelessly as a clinical and policy leader around child abuse prevention and perinatal substance abuse. Prior to coming to Santa Clara Valley Medical Center, Dr. Russell served as the Deputy Health Officer for the County of Ventura, where he served for more than 13 years. Paul again continued his work at innovating new programs and services to meet the needs of the community, especially the underserved. During his tenure, Dr. Russell initiated a prenatal screening program for women at high risk for drug and alcohol use during pregnancy, a program that has since become a standard of prenatal care. Dr. Russell relaunched and expanded programs to prevent child abuse and child deaths in the county, including the formation of a clinical review team to investigate all unexplained deaths in children under 18 years of age. In 2013, Dr. Russell joined the County of Santa Clara and Santa Clara Valley Medical Center as the medical director for ambulatory care and community health, and was then appointed as the director of primary care, where he played a key role in expanding clinical services and capacity to meet the needs of our community. Dr. Russell was a strong supporter of foster children. He was instrumental in expanding the Spark Clinic, dedicated to improving the health and well-being of foster children. The program today provides direct access to medical, behavioral, dental, and legal services for our foster children. As Supervisor Ken Yeager mentioned, he was instrumental in expanding services to the LGBT community and advocated with many in this room to establish and operationalize the first transgender clinic at the Downtown Health Center, which will provide integrated clinical services for both adults and youth. Dr. Russell was actively involved in many, many projects and innovative efforts, including the establishment of a post-care transitions team to transition patients effectively from acute care hospital, Valley Medical Center, and establishing an innovative homeless healthcare multidisciplinary clinical team in partnership with the Office of Supportive Housing. Dr. Russell also continued his work as an expert in fetal alcohol syndrome and participated in ongoing research on the subject. In short, Paul's outreach, innovation, and tireless effort to serve our community were impactful. Paul will be missed, and we are all thankful, all of us here today, to have been able to work with him and to get to know him as a true friend, a respected colleague, and as a kind, compassionate, and generous man.
Thank you, Paul. And I know you were primarily responsible for recruiting him and having him come up here, and being able to work and continue your friendship with him here, I know meant a lot to both of you. Mary Ellen, I know you were here. I thought maybe if you could maybe stand along with your children, and so we could give a round of applause to you and to Dr. Russell for all that he gave to our community. Thank you. We're going to proceed on with our meeting. You're welcome to stay, but we certainly understand if you have other things that you need to do. Thank you. We'll move on to item number 4, which is to approve appointments and reappointments by the medical staff.
Good morning, Supervisor Yeager and Committee-and Dr. Smith. My name is Yvonne Kranis, and I am the President-elect of the medical staff. I'm here in Tom Wensing's place today. Thank you for allowing me to present the credentialing report. If you have any questions, I'm happy to answer them.
Thank you and welcome. Congratulations.
Thank you.
Supervisor Yeager, I believe all we need is a motion to approve the appointments and reappointments, and I'm happy to make such a motion
All
at this
right.
time.
Then we'll send that on its way. Item 5 is to consider recommendations relating to the monthly report from the Director of the Santa Clara Valley Health and Hospital System. Renee, I think we start with you with item 5A, Director's Report relating to emerging issues.
And thank you. Good morning, Mr. Chair Yeager and Supervisors Committee. We submitted a written report that gives you an update primarily on the governor's budget, some of the changes that are going there. In terms of what's notable, even though there were not any major policy initiatives expanding universal coverage, what was approved and hopefully signed today by the governor is an initial allocation of $60 million for an all-payer claim database that I think hopefully will get us towards a place of universal coverage, which I'm sure Dr. Russell would be very proud of in terms of the state of California and Santa Clara County. The second thing that I wanted to emphasize on item 11 that was put on consent, it is the federal managed care rule, but a couple notable things that are pending that will come back is I've asked Drs. Arnold and Dr. Cody to come back in December with a quality plan, given that so much of our revenue and services are dependent on performing on quality measures. And we have hundreds of measures coming to us that are linked to very specific payment systems. But I think from a care delivery perspective, as well as a public health perspective, it would be great to see which are the critical few that yourself, who's been a big champion on the quality end in terms of the services that we provide, as well as the Health and Hospital Committee, could benefit from receiving annually. So it'll be something that we'd like to establish beginning in December. And I know Drs. Arnold and Dr. Cody are working very hard with our teams to identify those few. That concludes my report, unless there's any questions about the written parts of it.
No? Anything else then to add there? And remind me when Bert is going to speak to us.
I think, Bert, it's part of my director's report. This is the federal update. Margolin is here with us and give us a summary of the year end, as well as what to anticipate in terms of the outlook for the next fiscal year.
Welcome, Bert.
Well, thank you very much. Happy to be with you. We are entering the final months of action in the Congress, and the original plan by the congressional leadership was to end this session with as little controversy as possible and return to the regular order on the appropriations process and avoid high-profile fights. It's an election cycle, and that was the plan. Of course, that's not the reality we're facing. Congress is tying itself up in knots over immigration policy, and the president is suggesting that he might shut down the government in September if he doesn't get his border wall funding. So there's more volatility to what's going on in Washington than we originally thought there would be this summer. Nevertheless, we think we know the broad outlines of where we are on health policy and what to expect in the next few months. Let me start with congressional action. Congress is very close to formally and finally giving up on ACA repeal and replace and block granting Medicaid. I say very close as opposed to definitively giving up on these issues and putting them behind the Congress, because the House of Representatives just yesterday unveiled a budget reconciliation plan that would in fact repeal the ACA and would in fact block grant Medicaid. So the House hasn't given up yet. I think as a practical matter, the chances of what they're proposing having any real life is very remote, but it's out there. They're keeping the issue alive. There are still some senators talking about returning to the health care debate as well, but I think most of those comments are largely symbolic. An example, though, of a concrete action is a press conference that former Senator Santorum is going to have in about 2 hours in Washington, where he plans to unveil a new repeal and replace plan supported by a group of a coalition of conservative organizations. You may recall that it was Senator Santorum who got Lindsey Graham and Senator Cassidy end of last year to revive the fight and produce the Graham-Cassidy plan after we thought it was dead during the summer, came back thanks in large part to what Senator Santorum did. So again, the Senate leadership, though, is very firm about not wanting to return to this fight. I don't think it's going to happen, but you'll hear some talk about it. There'll be this Santorum plan unveiled later today and at least some discussion about it. On budget cuts per se, the House plan calls for $150 billion in safety net cuts, which could include health care. Again, I think we're unlikely to see significant health care cuts in any final budget agreement reached in September. There are other budget threats that have come and somewhat gone, and the main one I want to highlight is the rescission effort. This is the power the president has in the middle of the budget cycle to identify savings the president wants and to propose to the Congress that he's freezing these funds, not allowing them to be spent, and if the Congress agrees with that by majority vote, within 45 days, the cuts are permanent. So the Trump administration, starting 3 or 4 months ago, was talking about a $50, $60, $70 billion rescission package, very big cuts. They whittled it down to $15 billion. The House has passed it. It's in the Senate. It may or may not become finally approved. We don't know yet. Half of those savings are from the CHIP program, what used to be called Healthy Families here in California. So at first there was some concern about that, and there still should be some concern that they're moving money out of CHIP for this purpose, but the money they're moving out is from the CHIP Reserve Fund. These are not operational dollars that will impact California or any other state. They're the reserve funds that are there in the event of a recession, other dynamics that could increase the need for CHIP. Not a good idea to get rid of them, to take them out of the reserve fund, but it's not an immediate threat to us. There's also been a great deal of talk this year about the 340B drug discount program being changed at the federal level. We know there has been a fight at the state level all year long, and just within the last several days, that fight, at least for the moment, was resolved with the governor's proposal being dropped from the budget. So while there are still discussions going on and still the possibility of 340B state action this summer, that appears to be diminished as a threat. And Congress talked about doing something similar all year long, and now they appear to be unlikely to act legislatively. That could change, but again, it's not likely. There is one positive development, though, on the 340B front, and that is that Congresswoman Doris Matsui actually introduced last week a bill, the first bill of its kind, to affirmatively endorse and support the 340B program as most safety net providers envision it. In other words, what Congresswoman Matsui is saying, essentially, in her bill called the SERVE Act, is that it's proper for safety net organizations to benefit from 340B discounts and use those funds to sustain their larger work, and that not every dollar has to be tracked back to a discount given to an individual patient. The opponents of 340B have been saying that unless you can track the savings back to individual patients, it's an abuse. Safety net providers have said that's not the case, and Doris Matsui now has a bill to advance that idea. She also would fix the Medicare reduction in 340B funding that was implemented several months ago, where essentially the Trump administration said we're going to, in Medicare, take away the savings from 340B. She tries to reverse that with her bill. So that's what's going on in Congress. There's even more activity on the administrative side of the equation. That's where there's been a lot of really serious activity and with real impact the last few months. We have work requirements under Medicaid. It's the policy of the Trump administration when you do a Medicaid waiver now to require the state to impose a work requirement. There have been 4 states thus far that have actually moved ahead with work requirements under their waivers. More states are in line to do that. That's advancing, work requirements under Medicaid. There is a regulation that was just, the comment period just ended on this regulation involving short-term insurance, allowing people to buy short-term insurance that would last not just 4 months, as current law allows, but up to 1 year. What's the objective here? It's to take younger, healthier people who might otherwise join Covered California and be part of the pool for the ACA and give them a less expensive insurance option that also provides less coverage. And again, there's some value to allowing longer-term insurance for the individuals who purchase it. I'm not saying there isn't, but the intent here is to make the ACA and its pool less cost-effective and to damage the ACA. And that's, again, comment period just ended on that. There's another rule that was just issued in final form, which would allow individuals and small employers to have an expanded ability to come together and become an association that would cross the state lines to purchase health insurance. Again, this would exempt these individuals and these companies from the essential health benefits requirement. The coverage would be less expensive. There's been a history with these association plans that cross state lines of some level of fraud and abuse that's in their history, in their past. But again, the main intent here appears to be to drain younger, healthier people away from the ACA coverage and give them another option. And again, if you want the ACA to work and you're trying to keep the costs of the ACA down, you want the healthier people to be in the pool. And this is another regulation that would take people out of that pool. There is another rule that we're in the middle of the comment period for that doesn't deal with the ACA per se, but goes after Planned Parenthood. And it's aimed at the Title X funding program, which is the only federal grant program that specifically is focused on family planning services. This rule has been referred to as a gag rule because it would prohibit healthcare providers who receive Title X funds from discussing abortion options with patients, except under very, very narrow circumstances, limited circumstances. But its main goal is to push providers like Planned Parenthood out of the Title X program by requiring not just this gag, but a financial and physical separation for any abortion services that are provided by the organization if they're to if they're to receive Title X funding. The cost of creating this financial and physical separation, the physical separation, a totally separate facility, is the main hammer here, would far exceed the value of the grant. And again, its intent is to sort of push Planned Parenthood out of the Title X program. There is, that's the regulatory front. A lot of action, a lot of activity, a lot of it moving forward. And again, because of the nature of regs, much harder to stop. There's one litigation issue, and I'll close with this, Mr. Chairman, as the final piece of my report. There's one litigation issue that involves the Texas Federal Circuit and that we should be aware of. Unclear how serious a threat to the ACA it is, but it's not unserious. There are a lot of resources behind it. The case is Texas versus Azar, and it's a case brought by the state of Texas and 20 other anti-ACA states, essentially alleging that when the tax penalty was taken out of the individual mandate, as was done in tax reform last December, individual mandate is on the books, but that tax penalty is gone, that when that was done, the legal rationale for other key provisions of the ACA disappeared. And the provisions that in particular they're citing as now no longer valid are things like guaranteed issue and community rating. These are the provisions, those are the technical terms for the provisions that essentially allow people who have pre-existing conditions to be given health insurance. You have a guaranteed issue, can't be denied, and you have a community rating, which means you can't be priced based upon your individual health history. So why is this at risk? The simple answer is that when Chief Justice Roberts led the court in 2012 to uphold the ACA, he didn't rely upon the Commerce Clause, the notion that this is justifiable use of the federal government's ability to regulate interstate commerce. He instead relied upon the fact that there was a new tax that was being created here, and the federal government had the authority to create this tax, and this tax was the legal rationale the court used to uphold the ACA, these provisions of the ACA. So the anti-ACA states see the logic of the Roberts decision. They see that that tax now no longer exists, and they're saying that we think we have a chance now to blow up the ACA. Again, that's been out there for a matter of weeks. The threat got a little bit more serious this last week when the Trump administration, through Attorney General Sessions, said formally, which is very, very unusual, they're not going to defend the ACA in this lawsuit. This is a lawsuit against the federal government. It's Texas versus Azar, and Attorney General Sessions said, we're not defending the ACA on these grounds, which essentially puts them on the side of getting rid of pre-existing condition protections. So that's out there, unclear how serious it is, except it's out there and can't be ignored. And that completes my report, Mr. Chairman.
Thank you, Bert. Very comprehensive. Thank you. And even though, again, as we move into the summer, it sounds like there's a lot still going on. So thank you. Supervisor Simitian, any questions or comments?
Thank you very much, and thank you for the pace of the delivery today, Mr. Margot.
You're welcome, Supervisor.
All right, we're going to go back to 5B, which is to receive a verbal report relating report from the Working Partnership USA. Mr. Brownstein.
Good morning. At the last session of the stakeholders group, there was a set of presentations regarding teenage health and young adult health. Dr. Sarah Lewis from the Public Health Department gave a sobering presentation about the increases in the incidence of sexually transmitted diseases in the county and the department's struggles to try and contain that problem. Planned Parenthood made a presentation appropriately enough about the impact of Title X changes. And one of the most interesting presentations was from one of the school health clinics, the Washington School Health Clinic. Dr. Angela Bymester made the presentation and indicated the very tremendous extent to which that clinic is integrated into the neighborhood. That is, people in the neighborhood don't just come into the clinic, but talk about what happens at the clinic, neighbor to neighbor, pass information about how the clinic is valuable. It's not a remote facility. It's very much an internal part of the neighborhood facility. And I raise that point, not that we don't need additional reasons to be worried about gentrification, but this is another reason to be worried about gentrification, because damages to cohesive neighborhoods not only have impacts on kids in school and on employment opportunities, they also have impacts in terms of these integrated health networks that won't function if the relationship between the clinic and the neighborhood is broken because people are forced to live in other areas because their housing is being eliminated. So I know the county's deeply concerned about this issue already, as I am. We have more reason to be concerned. Thank you.
Thank you, Bob. And then, Supervisor Smitty, what I'd like to do on 5D, E, and F, because they're all related to behavioral health, take them as one item. And before we hear from our Director of Behavioral Health, we have two speakers, Scott Largent and Alyssa Koff-Ginsburg.
Hi, good morning, everyone. Scott Largent. The two items I selected on there, just as far as the behavioral health issues. Good morning, Tony. I guess what I've been trying to work on is what happened to me getting my property taken. It's never been fixed, and I kind of got. Just long story short, they said they were rolling things out. They put things on their website. They being the San Jose Police Department. When you go an independent police auditor or the internal affairs, this stuff's just not there. People go in there to complain, it's not there. Public Defender's Office, they told me everything I wanted to hear, sat down, had meetings, said, okay, we're going to do this, we're going to do this. So periodically I send people in there, not just myself. I send them in there to ask about, hey, my property was taken. Hey, this happened. The people at the front are like deer in headlights. They're like, oh, we don't know what to do. They send you there, they send you there. So they're still just not paying attention. I'd say about 20% of the people that I knew on the streets, well, not necessarily the people I knew, they were really, really bad people. The other 80% were just struggling and trying to survive. In the chronological report when my motorhome was taken, people would call in and make fake allegations about stuff I wasn't doing. I got permission to be in parking lots. I used to clean them at night. You know, I knew the neighbors in areas I was at. I never lied that I was a meth addict, but, you know, I got to know these people. I didn't bother them. But the stuff that was coming through, one thing on the chronological report that they called in said I was tapping into a utility pole. I mean, that's like trying to commit suicide. I never was doing anything like that. Then that I was blocking my license plates with chairs and different equipment, that I was stealing things from the department store down the street. I mean, these allegations were pretty sad, and that's what a lot of homeless and mentally ill people are having to deal with. I just don't think we should take everybody's stuff and start to create that nanny state to take care of them. Just let them have some of their last belongings. My stuff meant something to me, and a lot of people I'm talking to, it's the same way. So thank you.
Good morning. I'm Elisa Koff-Ginsburg with the Behavioral Health Contractors Association. Our members were very excited to see this report on capacity on the agenda. We really appreciate all the work that department staff has done to put this together and realize it's a very important step towards strengthening our system. We look forward to working with Tony and her colleagues to better understand it. I just also want to mention that we're very hopeful that the rate adjustments that Dr. Smith referred to yesterday in the board meeting, the process in the first 3 months, will allow providers to hire and retain staff and fully actualize the capacity in the system. So I hope that when we're all looking at this report 6 months from now, it reflects more capacity available to those who need the services. Thank you.
Thank you. Tony, we'll turn these items over to you.
And I will be brief. I want to thank the board members for supporting our MHSA plan yesterday. And I'm going to highlight in both my report and the other two items quickly. I think the big pieces of work I want to bring to your attention right now are we're working very closely with the CEO's office on the rate increases. The other thing that we'll be bringing forward to the CEO's office is information on HealthLink and NetSmart, as I've raised before, just in terms of compliance with 42 CFR. The other big thing for the department, which we spent yesterday afternoon doing following the board meeting, is really looking at the contracts effort. We're working very, very closely with the new Chief Procurement Officer, and we have identified that the department alone has 580 programs that are contracted out in multiple contracts. And so there's a lot of work going on between the county procurement office and our team, really trying to look at all of the procurements, especially those with new requirements. So it's going to be something on my reports on a regular basis. In terms of the other two reports, substance use is doing extremely well with waiver development. We're actually serving as the pilot for an external quality review, the first in the state for substance use, which will be on board very soon. And the area of most focus is the capacity report. We're now required by the state, all counties, to submit a detailed individual provider by provider tool to demonstrate where the capacity is and is not. We had already launched the system assessment before the tool was required, and all of the gaps in our system have been funded through the MHSA plan that you've just approved. So we know where the gaps are, and we'll be working really hard, working with providers and our team to get those gaps filled, hopefully in the next several months. On the substance use side, the demand for those services is really increasing. We need 5 additional detox beds, and at this moment, about 200 additional outpatient treatment slots. So Bruce Copley and I are working with HHS and OBA. Those services are now billable by Medi-Cal, but we cannot use our mental health match funding to support strict substance use services. So we're going to need to look at our existing general fund. But it's fair.
Thank you. You know, I just have a couple questions. As was brought up at the board meeting yesterday, I'd like to reiterate my colleague's recommendation to staff up our mobile crisis team with the clinicians that we have available, and then work to expand service hours. One staff, maybe we can consider a temporary rotation of teams to cover night shifts. That's
Well, we're trying.
Okay.
We're working really closely with HR to determine what other opportunities do we have to get people into these positions, and I'll keep that monthly on my report. It's our high priority, just like it's your high priority. It's also the community and law enforcement's high priority.
And then also I was pleased to hear the sobering center utilization is up 43%, and that's great. I know we're still waiting for San Jose PD to begin using the center. Do we know what is holding up that MOU, and is there anything that we can do?
Chief Garcia went to the sobering center and met with the team yesterday afternoon and was very enthusiastic, so we think that's going to be moving forward pretty quickly.
Great. Supervisor Smidian?
Thank you. On that same point, forgive me, I've just forgotten. In looking at the page 3 of the monthly update, we've got folks from Campbell, Mountain View, and the sheriff's office. Is that because we've negotiated agreements with those 3 departments? What?
It's been different with each of the law enforcement.
And let me just, and I don't mean to make light of this, but I mean, I immediately was struck by the fact that roughly a quarter of the folks in the system in April were from Mountain View, a community I represent, where the population represents maybe less than 5% of the entire county population. So you could easily ask yourself, is there a problem there? And the answer is, I think, no, there's not a problem there. There's actually some good news there, which is that that's a department that we're connected to and that's using our services. Am I drawing the right conclusion? Let's start there.
You are.
And then understanding that we have 15 cities and towns, some of which use our sheriff's department, some of which have their own independent police departments. Where are we in terms of getting folks to see this as a resource that they want to use?
There's something going on this afternoon. There's been a huge outreach effort with Javier Aguirre and the Reentry Center and with Bruce Copley in substance use, because it's actually a substance use program. We've met with all of the chiefs. They've met individually with the different police departments, and the one that we've most wanted to bring on board has been San Jose, because that's where the population is. Chief Garcia has been working with the city attorney to get that agreement in place, and I think his arrival yesterday and desire to see the sobering center was very positive. In the south part of our county, there's an arrangement that's been made with Gilroy and Morgan Hill to address these needs, and we're working with Dr. Miller and some of the pilot work on that one. So I want to leave you with an understanding that we're being very aggressive working with law enforcement, and some have joined and some have just not had clients to come forth.
And is the geography or location, I mean, initially I thought, well, maybe the geography and the location's the impediment, but if the alternative is to book somebody anyway, that doesn't strike me as the impediment. Again,
I think you're correct there. I couldn't explain why all of the smaller law enforcement agencies, there is some geography, and I know that a couple of the law enforcement agencies have held a cell open just for somebody to dry out. That's been the practice historically. You're seeing pretty steady increases in terms of the use of the sobering center. So if you want more, we have lots of detail. We can provide you with more detail next month.
Well, I'll ask my staff just to follow up with you offline. At the risk of stating the obvious, Palo Alto is right next door to Mountain View, so the geography wouldn't really be more of an issue for one than the other, one would think. And yet, we've got robust participation by Mountain View, but not by Palo Alto. Sunnyvale's even closer, and they, of course, have a somewhat different public safety arrangements or structure there. But it sounds like there's a different story in every community, depending in part on who's in the leadership positions. All right. Thank you. Thank you, Mr. Chairman.
Thank you. And then Supervisor Smithien will approve item number 5. We move on to item number 6, referral report from the health officer.
Good morning, supervisors. Sarah Cody, health officer. Just a brief report. One, I wanted to bring your attention to a new CDC policy that was just announced to our TB controllers at the end of May. The technical instructions haven't been finalized, but I think it's going to have a significant impact on our county, so I wanted to bring it forward. And that is that new arrivers to our county, immigrants and refugees, are generally screened for TB, but the latent TB infections aren't reported to counties. And the change will be a simplification that they will now be reported to counties. We think this is a really good thing because if we ensure that those with latent infection are treated before they get active disease, we can prevent illness, hospitalizations. But it's very new, and because there's over 30,000 of these new arrivers who get TB screening in the state every year, and about 8% of them come to Santa Clara County. So it will be a significant impact. We will be looking at a way where we can evaluate them, link them to care, and ensure they get treatment. So we anticipate the policy to be taking effect sometime this fall, probably in October. We would be getting the first reports to the county of new arrivers with LTBI. The other updates that I have, we were invited to participate with a smallish group at the state level to frame to address violence prevention and think as a state about what's the public health role in violence prevention. And 3 areas were prioritized: gun violence, intimate partner violence, and child maltreatment, and thinking about all the work that we do in public health and how we bring that together to help prevent violence. And I was looking at the notes from that meeting, and then I was just thinking about our national situation and the public health crisis that's emerging along the borders. And you may already know this, but I just wanted to bring to your attention that the APHA has put out a statement about the likely public health effect of separating kids from their parents. And if you have time, I can just read this. I think it puts a lot of what we've discussed here into perspective, and it also made me think. I just think about Paul Russell when I read this. As public health professionals, we know that children living without their parents face immediate and long-term health consequences. Risks include the acute mental trauma of separation, the loss of critical health information that only parents would know about their children's health status, and in the case of breastfeeding children, significant loss of maternal-child bonding essential for normal development. Parents' health would also be affected by this unjust separation. More alarming is the interruption of these children's chance at achieving a stable childhood. Decades of public health research have shown that family structure, stability, and environment are key social determinants of a child's and a community's health. This practice places children at heightened risk of experiencing adverse childhood events and trauma, which research has definitively linked to poorer long-term health. Negative outcomes associated with adverse childhood events include some of society's most intractable health issues: alcoholism, substance misuse, depression, suicide, poor physical health, and obesity. Again, this is a statement by APHA, the American Medical Association, and American Academy of Pediatrics have put out similar statements. So this really is a public health crisis in the making. Now, completely switching gears, I just wanted to give you a few small updates about operational progress within the Public Health Department. One is, I think I saw Nari earlier, we are expanding access to immunizations through a partnership with Valley Medical Center HHS pharmacy. So pharmacists will be giving immunizations. And at our Lenzen clinic, what that means is that we're going to be able to combine our existing immunization clinic nursing staff with pharmacy staff to expand access to immunizations, which is fantastic. We're quite excited about this. And I also, you may not remember, but years ago, you approved an assistant public health laboratory director. This was part of our vision of ensuring that our infectious disease response function of the public health department was solid, and this was one of the positions we thought was really critical, and we have just landed a person in the position. After many, many years, this is just a blip on the radar, but it's actually, it's a very significant event. And even though you don't remember how you supported it, thank you again, and it has happened. And as you know, we are continuing to recruit now for 2 deputy positions, both our deputy director and deputy health officer positions, which are vacant. As we do that, even though those spots are vacant, we will begin our next 3-year strategic plan for public health, which I think will fold into what Renee mentioned, the quality measures, just thinking about health more broadly. It will be a challenge without Amy Reedy, of course. She's sort of been, I think of her as the chief nutritionist for the department, keeping us all healthy and doing our best. But we're nimble, and I think that we have quite a bit of bench strength, and we'll be great. Thank you.
Thank you for that report. We will then forward that on to the board. We move on to item 7. This is a report from the Emergency Medical Services relating to the status of the EMS agency and EMS system for calendar 2017. Welcome.
Good morning, members of the committee. I'm Jackie Lowther, the EMS director, and we are quite pleased on our 2017 report. The EMS agency monitors and evaluates the quality of advanced life support and basic life support and of the care that's provided to the people of and visitors to Santa Clara County. The EMS agency is bringing innovative practices to the community, which has the potential for improving patient outcomes. Over this last year, in 2017, our system served 1,938,152 people, averaging 361 responses per day, resulting in 235 transports per day. In 2017, the Santa Clara County EMS agency, working together with the fire chiefs and public health, put together this life file, which is the life-saving information for emergencies. This pouch, and if the clerk of the board would be so kind to pass these out to you, which we haven't done before. This form is a great asset to first responders. It's placed on the refrigerator, and they have all the information they need on past medical history, any allergies or any medication that you might be taking. This is very popular for the first responders and is great in improving care out in the community. The EMS Trust Fund, the slide on the right, has provided $500,000 for AEDs, 700 AEDs out into the community over this last year. This is a program we would very much like to continue to serve the community. Training was provided on many aspects: psychological first aid, airway management, preparedness, and resource allocation. One of the first things that I was asked to do by the Harvey Rose audit, it was recommended that the EMS agency provide information to the public on when to call 911. And at this time, I would actually like for you guys to be able to see this. It'll only take a minute but I think we were very impressed by this.
Most people know they should dial 911 to report a crime in progress. A fire, a car crash, especially if someone is hurt. But do you know which medical emergencies require immediate attention provided by dialing 911? If you or someone else is experiencing any of the following, dial 911 immediately. Severe difficulty breathing and/or severe allergic reaction. Chest pain and/or a fast heartbeat while at rest. Difficulty speaking, numbness or weakness of any part of the body. Sudden dizziness, weakness or mental changes, and/or sudden blindness or vision changes. Broken bones visible through an open wound or a broken leg. New severe headache or other sudden intense severe pain. You witness someone faint or pass out, or someone is unresponsive. Heavy bleeding from your mouth, nose, or private areas. Bleeding from any wound that won't stop with direct pressure. Drowning or choking. Severe burns, or someone who's extremely hot or cold to the touch. Poisoning.
Well, we can just leave it at poisoning.
Okay. Just leave it at poisoning, right? It won't advance either. We stopped it at poisoning, right? One of the opioid crisis. It froze. The EMS system did care for 1,139 non-traumatic sudden cardiac arrest patients last year, which demonstrates 59 per 100,000 cases, which is slightly higher than the national average of 55. The unfortunate part, which is what we're working on, is only the use of AEDs, or the automatic external defibrillator, is only used 3.5% of the time, which leads to a lot of education to the public. We have them in all the school districts in the county, and are working on getting them in all the first responder vehicles like the police department, sheriff. But if 3.5%, the national average is 4%. There's a lot of education that needs to be done. When cardiac arrest patients are found and are in a rhythm like ventricular fibrillation, where the heart is still fluttering, or ventricular tach, and are able to get an AED to them, the response rate for restarting that rhythm is 62%. So it's critical that we get to them quickly and be able to offer that life-sustaining AED to them. Diversion, we've talked about wall times before, but diversion and wall times are still an issue. We're one of the few counties in California that still have diversion, and we're working with all the hospitals, but they've done a great job. The slide that we showed was from 2017, but it's been a great progression with all of the hospitals, and the current diversion for May was everyone, no hospital was greater than 25 hours, and no hospital exceeded 31 minutes for offload time. So it's been a great progression. Stroke, we're on 9. There. Stroke, this is another great incentive for education for hospitals. 48% of the time, the public calls for 911 for stroke, which means a great percentage are still driving themselves to the hospital or having a family member. So we've got a great campaign for 2018, 2019 to inform the public, please call 911. Care is rendered much quicker when they arrive by 911. The bottom green is the interfacility transfers. Those are up significantly over 2016, and the reason for that is the reporting by the hospitals. Our data reporting has increased significantly, and we're getting more data. Trauma is still, motor vehicle accidents are still the number one between the years 25 and 44. Ages over 65 increases in falls. So motorcycle crashes, we do not get data from the medical examiner's office, so this is only the data that is reported for those that are transported to the hospital. This is a very busy one, but our 3 trauma centers are extremely busy. Our busiest, Valley Medical Center. I tried to color code it so you could see the blue is motor vehicle crashes, followed by falls, assaults, and the numbers. So 38% are going to Valley Medical Center, 32% to Stanford and Regional Medical Center at 28%. But it gives you a good idea of motor vehicle crashes still as the number one. And disaster response, our response, the medical health mutual aid is shared between the EMS director and our public health director. But we did, this just kind of illuminates our response to the North Bay fires. But there was a great response from not only public health, the EMS agency, environmental health, as well as a person from Valley Medical Center, but the medical volunteer disaster response. Behavioral health was a tremendous help in this to aid and provide mutual aid to our neighbors to the north. So a great deal of training needs to continue in case we need to be ready for a reciprocal response in the future. Having the EPCR system that we do is very necessary so the EMS agency to approach quality assurance and quality improvement. The unification of the data system sends data from fire to the EMS ambulance, then on to the hospitals. This has to be really kind of tweaked a little bit so that we can get that data not only to the hospitals, so that we can get data back and get outcome data. That is our goal for the future. But it is a fairly robust system. And in summary, our primary goal is to provide the highest quality for those in need of emergency medical services to the county through our coordinated networks of paramedics, EMTs, nurses, physicians, and other EMS professionals who work together with a strong commitment to excel in all aspects of patient care. The EMS agency will continue to achieve and exceed this goal. We thank our partners, the board, and the executives for their support all year, and all of the excellent staff at the EMS agency. Any questions?
Well, thank you for that excellent report. I do have a couple questions for you. Do we have a sense for why we are seeing a slight upward trend in 9/11 ambulance responses to our VMC clinics?
Well, we have added clinics to the VMC clinic system, and we are currently working on a little bit of change on the jails. And what we are going to do once the IFT contract is in place is kind of sort through sort of a parallel process with them. But when they increase their clinics, we haven't quite been able to do that. It's been a very slight uptick. We've been trending it and working with them a little bit. I think our change, kind of tentative change at the jails will parallel at the clinics very soon.
Maybe when we see you in November, you could give us just a slight update, a small update.
That would be
on
great.
where we are on that. I noticed almost 4,000 EMS calls last year related to a behavioral or psychiatric crisis. When we have the new behavioral health mobile crisis teams fully operational, how do we plan to coordinate between EMS and behavioral health?
We are working very close with behavioral health. Our pilot program in Gilroy is working great. We've had 38 potential assessments out there, 18 enrolled in the community paramedic program. And I think as we work with Tony and the crisis stabilization sort of works, and we can figure out which of those we can hand off and which we can hand off to the police, we can further. Tony, do you have it's sort of a as we go. I think we're waiting on the rules of engagement here.
Yeah, there's quite a bit of work underway on this, Supervisor Yeager. So you'd ask to work with staff, both you and Supervisor Smitty, and we can provide a lot of information.
Great. I think it'd be great. Can you provide an update on where we are with the RFP process for the 9/11 ambulance contract?
Well, we have the review committee is engaged, and they are meeting and following all the procurement processes and the EMS authorities processes, but that's about as far as I can go.
All right. Then the last question, how is Rural Metro doing in terms of replacing its fleet of ambulances and installing the new radio equipment? Are they in compliance now?
They have supplied 22 out of the projected 50 they should have had by June 1st. And there's been not much discussion on the replacement radios. So, no, they are not as far as the fleet's concerned or the radios.
Okay.
So they've got a replacement. So we got one replacement ambulance this week, but we have 22 out of 50 that they've refurbished or replaced. And the radios are due by the end of 2018, so they still have some time with that one.
Is there anything we need to do to get them to comply, or is it just a matter of equipment not being available for them? I'm trying to figure out a little bit about what the holdup is.
It's a slow process for them, and I think part of it is the process of the RFP is going on, but it's a slow process to take those out of commission and bring on the new ones.
Supervisor Smitty?
Well, just to say thanks for the progress on AEDs, even as we think about what more we can do. You know, one of the challenges as a board member, and certainly I suspect for staff members as well, in a large organization like this one, is it can sometimes be a little challenging to move the great big battleship even in a slightly different direction. And I remember when we did I did an inventory item to pilot the use of AEDs, and I wondered if it would spark any interest, and it certainly did. And to give Supervisor Chavez a little bit of a shout out here as well, she saw the opportunity for us to do appreciably more, and we have done so much more. So you know, it's just one small piece of the healthcare work that we do, obviously, given the scope of our organization, but it was a place where I felt like we piloted it. It was well received. It worked. People showed interest, put some resources behind it from outside the county as well, and the growth of the program has been very gratifying to see, so I just wanted to acknowledge that. Thank you.
Thank you. With that, Supervisor Smitty, we'll get a motion to approve. There we go. That leaves us 2 items, and I know that you need to depart at 11:30, so I think we can wrap these 2 items up. I believe it's 8 and 11. Number 8 is to receive a report from VMC relating to operational, financial, quality, and safety updates.
Thank you, Supervisor. So today, obviously, you have in your package the detailed operational report, but I'm going to introduce Dr. Ahmad Kamal, who's going to give an update on GI, and this is one of the specialty services that we had been challenged with in the past, and I think it's appropriate for Dr. Kamal to give you an update in terms of our progress and our effort to sustain those improvements. So Dr. Kamal.
Well, thank you all for this opportunity to present. So today, as Mr. Lorenz said, I will be talking about some of the work we've been doing in GI, which I believe is representative of the great work being done throughout the system, ambulatory care and VMC. But before I start, I'd also like to just give a brief acknowledgement to Dr. Paul Russell, who 4 years ago sat me down and told me I should be involved in operational improvement and got me involved in the CLT project, and really started me on this journey that, you know, has been wonderful for me professionally and personally. And I was honored to know him, and I know I'm one of several hundred young and not so young physicians that he's mentored. So just like that. So our efforts at in GI are aligned with the HHS strategic roadmap, which all of us are familiar with, and this dovetails very well with the triple aim of the IHI, which is improving population health, improving the patient experience of care, and also reducing the per capita cost. So as a public health agency, we have a unique opportunity and an obligation to reach beyond our walls and improve the health of the entire county. And in this regard, we've been very fortunate to partner with the Public Health Department and engage in programs that raise awareness in the community. And this is one example of a program that Andrea Arce, our health center manager and public health, put together about Trust Your Gut, trying to get people involved in colon cancer prevention and screening. And it's an inflatable model of the colon you see over here that you were able to walk through, and all of us dressed up as vegetables and fruits and everything to try to emphasize the importance of nutrition in improving everyone's health. So this is just one.
I see an opportunity there for the chair of the health committee.
Exactly, exactly. You're welcome. You're welcome. We have plenty of carrot suits. So as gastroenterologists, we also have the opportunity to prevent colon cancer by removing colon polyps before they become cancer. And for the past 5 years, we've been tracking our efficacy in doing this, and we are very proud that every single quarter we have met or exceeded all national and regional benchmarks in our efficacy in removing these polyps and preventing cancer. Next slide. But this really doesn't mean very much if people have trouble getting into our clinics. And so one of our major initiatives has been around access improvement. And this slide here shows the historic backlog of GI clinic, which back in January of 2016 exceeded 3,000 patients who had an authorized referral and were not scheduled for a visit. And we are very proud that over the last 2 years, this number has fallen by over 95%. And we've been able to do this through various initiatives, including electronic consultation, where we provide advice to primary care physicians and patients without face-to-face visits. We've also been triaging every single referral within 72 hours of it coming into us to make sure that the referral is complete. And when we see a patient, we're able to do exactly what we need to do. And finally, we've also been very active in calling patients who have an appointment or have a referral and making sure they get into our clinic in a timely manner. And then for some people, just allowing them to directly come for a procedure rather than having a clinic visit first. So direct access colonoscopy has been one way that we've been able to reduce our backlog. Next slide. So another area we've been working on is our telephone access. So going back to 2012, we saw that the average wait time on the phone for a patient calling the clinic was in excess of 10 minutes, sometimes as high as 30 minutes, which, as you know, if you've ever been on the phone on hold, seems like hours and hours. And not surprisingly, our call abandonment rate was over 50%, meaning over half the people who tried to call us gave up before they even got through, which clearly was not what we aspired towards. So once again, we are very proud to say that in the most recent measurement, our wait time had gone down to 59 seconds, and our abandonment rate had been less than 10%. And the way we did this was that rather than expecting patients to call us, because that is a challenge for many people, we actually call them. We get a referral from their doctor, we review it, and we make sure they need to be seen, and we give them a call and say, hey, come on in. And that really has reduced our volume of calls, and as a result, the people who do need to call in get through much, much quicker. Next slide. And finally, I just want to say a few things about outside medical costs. And this is clearly an important issue that's very complex and beyond the scope of one clinic to fix. But one of the ways that we've been able to see a decline in the number of patients being sent outside for GI services is by strategically hiring people. So every time we have an opportunity to add a position in GI, we really take a deep dive into what the unmet needs are in our community and really work to find an individual who is going to fill those unmet needs. And because of that, it does sometimes take us a very long time to find the right person, months and up to a year sometimes. But we really believe this pays off in the long run. So as an example, a few years ago, we hired a board-certified hepatologist, a transplant hepatologist who has expertise in liver transplant. And we are the only non-academic medical center in the county to have such a person. But because of that, we're able to do a lot of the pre-transplant and post-transplant care at VMC. And this was a huge source of outside medical costs before we had such a person. Another example is our recent hire of Dr. Ann Chen, who is an endoscopic ultrasonographer. So EUS was a procedure we were sending out to Stanford, spending close to $500,000 a year sending this out. And she happens to be the best at this in the entire county, and we hired her. And now we all do it in-house. And so I think that's really been an example of us doing our part to try to reduce outside medical costs. But at the same time, I think it's great for our patients. I think trying to consolidate care in one institution really helps provide better care for them. It reduces fragmentation, it reduces transportation costs and time. So I think really just working with the operational group and trying to make things better has been extremely gratifying and successful to us, and I am open to any questions or comments.
Well, thank you. Really tremendous success. Something that you can be very proud of, and it's great that we've come so far really in such a short period of time, so congratulations. And thanks, too, for mentioning Dr. Russell and the support he gave you in this endeavor. Supervisor Schmidt? No other questions.
Thanks so much. Thank you.
All right.
I just want to say this is a great example of team coming together. I think the CLT team process really helped in this regard. GI used to be a service that was really difficult to access, and we sent a lot of people out. Now we're getting great access, total commitment from the team to quality care, not sending as many people out, so therefore reducing the cost per capita, and much more satisfaction from patients, and making sure that we hire the best and the brightest clinicians. So it's really a truly amazing success. So thank you very much.
Thank you for all your support.
All right, we'll move along to disaster preparedness.
Yes, so Supervisor Yeager, some time ago you requested that we give you an update from the VMC perspective of our preparedness, planning preparedness and readiness activities at the medical center. So I'd like to introduce Gilbert Gutierrez and David Fernandez from Valley. Gilbert.
Yes, as Paul mentioned, we're here because in December of 2017, Supervisor Yeager requested additional information regarding the readiness of Santa Clara Valley Medical Center to respond to a mass casualty incident. The comment was posed as hospitals around the country have faced the need to respond to terrorist attacks and mass shootings, which unfortunately have become far too frequent. The short answer to the question is yes. We are prepared to handle a mass casualty incident should it occur in our county. but with the caveat that we are ready. While we are ready, we continually look for ways to improve and enhance our capabilities to address such events. In the event of a disaster, Santa Clara Valley Medical Center has provision for minor, moderate, and catastrophic injuries. We won't, however, be responding alone. This slide shows a number of the other agencies that would respond to and be working with us in the event of an emergency, including a multi-casualty incident. The response, depending on the severity and expected duration of the incident, would start at the local county level, but can escalate to the regional level, state, and ultimately the federal level for assistance if warranted. In addition, we collaborate with other area county hospitals through regular emergency management meetings and training exercises facilitated by public health and emergency management services throughout the year. Communication is a key component in successfully responding to an emergent event, and so it is that all counties use a common language, if you will, to communicate. The common framework that all counties use are the National Incident Management System, or NIMS, and the California state version, which is referred to as the Standardized Emergency Management System, or SIMS. Hospitals similarly use a common system to manage incidents known as the Hospital Incident Command System, or HICS. These systems provide a common framework for initially responding to an event, developing the ongoing response, and requesting additional outside resources should they be required. Within Santa Clara Valley Medical Center, depending on the severity of the event, the hospital may choose to activate a single or multiple parts of its emergency operations plan. In addition, the hospital could also activate its hospital command center to begin coordinating efforts to address the situation. The emergency operation plan provides a framework to address anticipated emergent situations and gives the HICS command team information on strategies and factors to consider as they assess the event and determine appropriate next steps to address the situation. For example, activating the surge plan would be in anticipation of a sudden increase in patient census due to an emergent situation. The HICS command staff in this case would assess whether early patient discharges are necessary to care for more acute patients, can elective surgeries be delayed, etc. It would give them that framework as they consider factors to move forward. Okay, go to the last one. Go to the initiatives, yeah. And then finally, we'd like to briefly share some of the initiatives that we are currently working on to improve our response capabilities and readiness. We are currently restructuring our warehouse to improve delivery of emergent supplies and reevaluating our current decontamination facilities for larger scale events. The hazard vulnerability analysis is conducted annually to assess the risk of hazards and events that could affect hospital operations. And the number one hazard on our list really is earthquakes for this area. We are also working in conjunction with county communications to improve our communication capability and establish a radio link to our outlying and mobile clinics, and finally, staff training. It's important to understand that all staff, from clinicians to support staff, will have a key role to play in assisting us to respond to potential emergencies, and so therefore we train and drill throughout the year. So, are there any questions? That was, I know, a very brief summary, but...
Thank you, Supervisor Smith.
And forgive me if I missed this either in materials or in the presentation. When was the last time we had an incident that sort of tested us in this way that people could use as a point of reference?
So thank you for having us. Last week, there was an incident in the city of San Jose with 30 patients that they were contaminated in a swimming pool. Together with our partners from EMS, they worked the multi-agency plan. They distribute patients across the different county hospitals. Valley Medical Center received 4 patients. So we constantly do training, and we receive multiple incidents.
Were there any sort of lessons learned from that experience about what worked, might have been improved? I'm just curious, was there a takeaway from that experience?
Every time that we have that type of incident, we actually conduct an after-action debriefing. We conducted one with all the hospitals and EMS last week, and we actually put in a process improvement plan to solve some of the issues that came up.
Thank you.
Supervisor Smead, why don't we approve item 8 and 10, And then when you need to slip out, I have additional questions, but
Sure.
I thought at least we would
Move
both of
approval.
those. Thank you, and I support that, and then we'll move them on. And David, I think that at least all the items on the agenda have now been approved and sent on, correct? I was just, and I think what prompted this request was the mass shooting, of course, in Las Vegas, but any number of these instances will happen at night. I think of Pulse nightclub as well. Do we have do you do a kind of training where you have these kind of incidences at 2 in the morning and everybody has to, if you will, get out of bed and get to the hospital as quick as possible? And how do you ever really prepare for something quite at that level?
So we do trains and exercises. All the hospitals annually, we actually have a statewide exercise. So it's not just individual to Valley Medical Center, but all the county hospitals from every single county in the state practice routinely. There's different scenarios that we practice every year. And in terms of something like a mass casualty, like Vegas-style incident, our partners from EMS right now in the last few months have been working really hard to modify our MCI plan. We as Valley Medical Center, we're actually modifying ours as well. So we actually learning from every event that happens in the county, in the country. We actually take it very seriously, and we're trying to set up improvements to our processes.
So, and obviously staff is aware that on a 24-hour period, they could be called instantly to come into the hospital.
Correct.
And treat the patients?
Correct. We have notification systems in place, communication systems in place, where in the event that a mass casualty incident happened or a major disaster was occurring, that the communication would then activate and it would reach out. And again, the command staff, once the Hicks command staff is activated, they would then assess the situation and determine, again, depending on the severity of the event, the duration of expected of the event, how much of the staff to call in. Because in some cases, if it's a longer-term duration event, you don't want to have all of your resources come in at once. You have to kind of understand it may last several days. And so we've done some things, for example, during the Super Bowl, where we went and activated our command staff and went into a 24-hour mode of keeping that command staff there. But there were people that were allowed to rotate onto that so that we kept staff fresh and were able to respond.
Joe?
No other questions?
You good?
Forgive me.
Paul, anything else in your report?
Just a comment. So obviously we're talking about external disasters, but occasionally we'll have internal activation of our command center, and that happens quite frequently to ensure that we maintain the continuity of patient care at the hospital. And so there are many of us in this room that have been woken up early in the morning to activate the command center. And I think as we go through the process of improvement around this, we do participate quite regularly with the state and other agencies in our preparedness and readiness activities. The list that Gilbert provided in terms of our focus around communication, training, that very short list may seem short, but it is quite an intensive effort, ongoing effort throughout the year that we're engaged in.
Joe?
Thank you. This is just sort of well, first I want to say thank you to Supervisor Yeager for asking for the report. I remember when the request was made, I remember thinking, yeah, that's something we should take some time to talk about. The second thing I want to say is I think this isn't, over my years in public office, this is an issue that I have been concerned about for a very long time, which is our ability to respond in the event of an emergency, whatever the nature of the emergency might be. And, by its nature, it's something that is out of the ordinary and that tests organizations in ways that are different than they are tested during the day-to-day work that they do. And I guess what I want to say, and I know Dr. Smith stepped away for a minute, but we've got the rest of the team here, so I'll sort of just offer this exhortation as one member of our board. I don't think you are likely to get a lot of positive reinforcement for being ready. I don't think anyone will see it. I don't think anyone will give you a shout out for it. I don't think we'll be even able to measure it in some instances, although I think you can. And I guess what I want to say is I want to encourage you to stay at it. I know every drill I've ever been part of, people have moaned, groaned, complained, and griped because it's, you know, an intrusion on their day-to-day whatever, you know, right down to the most basic of fire drills. And yet, I think the experience tells us that if you haven't done the training and you haven't developed that muscle memory for just like go, then there's a consequence for that. So, you know, and appreciate Dr. Smith step back in the room. My exhortation to the entire team is, you know, we probably won't give you a proclamation for being really ready standing here in the chambers, but I really do want to encourage you to keep putting the time and effort into it. And again, I appreciate the fact that Supervisor Yeager was thoughtful about bringing this item forward, because you know, that day is going to come. It comes in greater and lesser degrees, but when that day comes, you know, your organization, our organization will be tested in a way that's really going to be quite demanding, and we will, to Supervisor Yeager's point, we'll either be ready or we won't. And enough said, but thank you.
Thank you.
Thanks. Maybe just to mention a couple other things, Paul. In your report, the post-acute care transition, the PAC teams, I was sort of wondering what our discharge practices are for homeless patients who receive their care for VMC, and what percent of those discharge patients are homeless, and that we then have part of the PACT team to take the transition.
Specific to the PAC team, and we've already started the project via a pilot to understand the impact and the results, the outcomes associated with that type of intervention. And I believe 95% of the patients that are going to be managed by the PAC team are homeless individuals. So a significant number of them, a lot of it is because the individuals that we're speaking of need to be stepped down from an acute inpatient setting to a skilled nursing facility. And so placement into those facilities are really important. And the ability to keep them not only in that skilled nursing facility, as opposed to being readmitted to hospital, is very important. But it's also important for that PACT team to step them down from the skilled nursing facility into the appropriate housing within the community. Because if we don't free up those SNF beds, then we're unable to move patients out from the acute care setting, and then we have a block in the availability of beds. So this post-acute care team is going to manage that patient all the way from the time of discharge all the way through to their appropriate setting within the community and keeping them healthy. And hand them off to other members of the care coordination team. And this is where, frankly, the whole person care team and coordination with the other parts of the system is critical, because many of these patients, I believe close to 60 to 70% of them, have a mental health issue, and that are actually within Tony's programs and services. So this whole coordination of care and the components that we're putting in place as a system are all interdependent. So this is one more step in I think, a very positive direction in really showing outcomes. And one of the outcomes that we're following, Supervisor, is the number of non-acutes that are within the hospital setting. And I think at one point in time, we were under 10 non-acutes on the medical unit when probably a year ago, and Dr. Smith knows this number really well, we were probably around mid-40s patients in the hospital. So not only do we see improvements in terms of the management of the system, we are also seeing the outcomes relative to patient care and our financial situation and well-being.
Right, and then my final question for either Bruce or for Renee. The VMC report indicates in May we saw another significant drop in the Medi-Cal expansion population covered by VHP, 4.7% decrease. Do we have any more thoughts about what is happening here?
Supervisor Yeager, it's we continue to have ongoing conversations with our counterparts at Family Health Plan, and they are seeing similar types of declines across all of their segments of business and in the county at large. So the reasons are pretty difficult to pin down very scientifically, but anecdotally, we certainly see we expect that it's a mixture of very strong employment in the economy, which is pushing household incomes above qualification level. Unfortunately, however, sometimes not necessarily accompanied by employer-sponsored insurance, so it's not necessarily a complete offset in terms of the uninsured population. And then anecdotally, ever since the current administration came into place, there have been some very credible accounts of families that may have undocumented members as a part of their household not wishing to be in the radar, so to speak.
Yeah, which is a whole other word, but thank you. Then we'll move on to item 10, keeping with you, Bruce. This is a report from the Valley Health Plan relating to activities, opportunities, and progress.
I'll be fairly brief, given the time today. Financially, the metrics remain quite stable. As Supervisor Yeager, you had noted, we do see an ongoing pattern of Medi-Cal enrollment declines. We also saw a slight decline in the reporting period in our commercial enrollment. However, at this point in time, as of current, we have actually gained another 400 covered California members, so we're up over what's reported here, and we are eagerly awaiting the results of the county employee open enrollment, and are optimistic that there will be a pickup on that. We are concerned about some of the harmful or potentially harmful policies that we heard about earlier today with respect to the ACA. On the other hand, we've seen over time that the well-constructed state-level exchanges, such as Covered California, are far more resilient to damage, if you will, from policies that are harmful to the exchange systems. And within the Covered California Exchange, we remain confident that in relative terms at least, Valley Health Plan's market position within Santa Clara County puts it in a somewhat less vulnerable position than other competitors. That's not to give any assurance that we're completely insulated from some of the effects of these policies, but we feel like we're about as well positioned as we can be. The remainder of our executive team is actually in Sacramento today with our annual review meeting with Covered California, and they may come back with some additional insight on how the leadership at Covered California is perceiving current policy trends, and of course we'll be passing that along as we learn.
Great.
With that, I defer to any questions.
All right, I think we're done, and David had said we've gone through our agenda. So with that, we'll adjourn and wish everybody a great July, and then see folks on August 8th, and we will certainly adjourn this meeting in memory of Dr. Paul Russell.